Let's discuss some high-yield key points on alcohol-associated liver disease. Alcohol-related liver disease, sometimes called alcohol-associated or alcohol-induced liver disease, represents a spectrum of liver injury related to alcohol use and spans from steatosis to inflammatory steatohepatitis and ultimately fibrosis and cirrhosis. Alcohol liver disease, or short ALD, is the leading cause of liver-related mortality in the United States, contributing to almost half of cirrhosis-related hospitalizations and more than 40% of listings for liver transplantation. There are three histologic stages of alcoholic liver disease. Alcoholic fatty liver or steatosis is the first stage, and at this stage, fat accumulates in the liver parenchyma. Alcoholic hepatitis involves inflammation of liver cells that takes place, and the outcome depends on the severity of the damage. And alcoholic-related cirrhosis is a liver damage that is irreversible, that leads to complications of cirrhosis and portal hypertension. Alcohol-related hepatic steatosis is the earliest form of alcohol-related liver disease, and by itself is a benign entity that can regress with alcohol cessation. However, steatosis is indicative of alcohol-induced alterations in metabolism and suggests susceptibility to progression to more advanced liver disease with continued alcohol use. It is seen in 90% of patients who are heavy drinkers. Continued alcohol consumption brings the immune system into play. Interleukins, with the help of neutrophils, attack the hepatocytes, and swelling of the hepatocytes, known as alcoholic hepatitis, takes place. Alcohol-related hepatitis, also called steatohepatitis, is an inflammatory intermediary in the development of alcohol-related cirrhosis and can be present indolently or fulminantly as acute alcoholic hepatitis. Of course, with alcohol cessation, alcohol-induced steatohepatitis can improve, although any underlying fibrosis caused by the inflammatory cells will remain. The risk of developing cirrhosis is higher when alcohol steatohepatitis is present rather than a simple steatosis. Alcohol-related hepatitis is a distinct clinical syndrome of severe steatohepatitis on a background of alcohol liver disease, often presenting with fever, jaundice, tender hepatomegaly, and leukocytosis. The final stage is alcohol-related cirrhosis. This is the end-stage byproduct of long-standing alcohol use brought on by maladaptive response of the liver to fibrosis in response to inflammation. Alcohol-related fibrosis and cirrhosis is largely irreversible, even with complete alcohol cessation. Approximately 25% of heavy drinkers develop cirrhosis. A 35-year-old man comes to your clinic for a routine checkup. He has a 20 years history of drinking at least 4 beers daily. He denies any history of liver disease, jaundice, or gastrointestinal bleeding. He has no significant medical history and takes no regular medications. On physical examination, his vital signs are stable. Is this patient at risk of alcohol-related problems? Yes, he is at risk of alcohol-related problems. To review, one standard alcoholic drink is considered any alcoholic beverage that contains 14 grams of alcohol. Examples of a standard drink includes 12 ounces of regular beer, 8 to 9 ounces of malt liquor, 5 ounces of wine, and 1.5 ounces of distilled spirits. Men who consume more than 4 standard drinks in any single day, or more than 14 drinks per week, and women who consumes more than 3 in any single day, or more than 7 drinks per week, are at increased risk for alcohol-related problems. Worldwide, approximately 20% to 30% of patients who present in primary care settings engage in hazardous or harmful drinking. It is recommended that healthcare providers, such as yourself, screen for and counsel risk drinkers as part of their routine medical and preventative care. Is there a tool that we can use to screen for unhealthy drinking in this patient who drinks at least 4 beers a day? Yes, there is. Various questionnaires and risk scores should be utilized, such as CAGE and AUDIT-C, to screen for alcohol use disorder, although the presence of unhealthy alcohol intake alone is sufficient to warrant screening for liver disease. The Alcohol Use Disorders Identification Test, AUDIT-C, is an alcohol screen that can help identify patients who are hazardous drinkers or have active alcohol use disorders, including alcohol abuse and alcohol dependence. The AUDIT-C is scored on a scale of 0 to 12. Scores of 0 reflect no alcohol use. In men, a score of 4 or more is considered positive. In women, a score of 3 or more is considered positive. Generally speaking, the higher the AUDIT-C score, the more likely it is that the patient's drinking is affecting his or her health and safety. Again, a positive result should prompt a more in-depth assessment of the patient's alcohol use pattern and a formal evaluation for an alcohol use disorder. Once we have identified patients who are hazardous drinkers or have alcohol use disorders, including alcohol abuse or alcohol dependence, we should assess them for signs and symptoms of liver disease, perform a physical examination, and to order appropriate lab tests and imaging studies. Patients with alcohol-associated fatty liver are typically asymptomatic. Those who have developed cirrhosis may experience jaundice, weakness, peripheral edema, abdominal distension, or symptoms of gastrointestinal bleeding, such as hematemesis or melena. Patients with hepatic encephalopathy may report sleep disturbances and confusion. Patients with steatosis may exhibit normal physical examination or hepatomegaly. Those who have developed cirrhosis may present with stigmata of chronic liver disease, such as spider angiomata, pulmonary erythema, or gynecomastia. In cases of hepatic decompensation, patients may develop ascites, peripheral edema, or hepatic encephalopathy. The classic finding is moderately elevated aminotransferases, with an AST to ALT ratio greater than 1, often greater than 2. Elevation of bilirubin in a patient without cirrhosis should raise concern for alcoholic hepatitis, and patients who are malnourished or have cirrhosis may exhibit low albumin levels. Hematologic findings in patients with alcoholic liver disease may include thrombocytopenia, anemia, elevated MCV, decreased lymphocyte count, elevated ESR, and elevated INR. Microcytosis suggests long-standing disease and may result from vitamin B12 or folate deficiency, alcohol toxicity, or increased lipid deposition in red cell membranes. Thrombocytopenia may be due to primary bone marrow hypoplasia, usually brief and alcohol-induced, or splenic sequestration due to portal hypertension and splenomegaly. Transabdominal ultrasound, abdominal CT, and abdominal MRI may show signs of hepatic steatosis or cirrhosis in patients with alcohol liver disorder. Here's a case of a 48-year-old man presents to your clinic for a routine checkup. He has a history of drinking at least 4 glasses of wine daily for the past 10 years. He denies any significant past medical history and has no current complaints. Physical exam is unremarkable except for a mild hepatomegaly. Lab results shows an AST of 60, ALT 35, total bilirubin 0.8, albumin 4.2, and a platelet count of 175,000. An ultrasound of the abdomen shows increased echogenicity of the liver consistent with fatty infiltration, but no masses or evidence of cirrhosis seen. What is the most appropriate next step in the management of this patient? Refer for liver biopsy, start antiviral therapy for hepatitis B, advise strict abstinence from alcohol and provide nutritional counseling, prescribe steroids, or schedule a follow-up MRI of the liver. The correct answer is C. Advise strict abstinence from alcohol and provide nutritional counseling. The patient's clinical presentation and ultrasound findings are consistent with alcohol-related hepatic steatosis. The mildly elevated AST to ALT ratio, along with a history of significant alcohol consumption supports this diagnosis. The most appropriate management at this stage is to advise strict abstinence from alcohol to prevent progression of liver disease and provide nutritional counseling to support overall liver health. Liver biopsy is not immediately necessary unless there are other concerns or unclear diagnoses. Antiviral therapy and steroids are not indicated in this case, and an MRI is not required based on the current findings. So what exactly is hepatic steatosis? Hepatic steatosis is defined histologically as the presence of fat on liver histopathology. Steatosis from alcohol use is indistinguishable from steatosis related to non-alcoholic fatty liver on both histopathology and imaging. Therefore, clinical history is paramount to get the right diagnosis. Various imaging modalities, particularly ultrasound, may also show evidence of steatosis and hepatomegaly from fatty infiltration of the liver. LFTs are classically normal in hepatic steatosis, although with ongoing alcohol use, it is not common for LFTs to be minimally elevated but should return to normal with alcohol cessation. Here's a case of a 48-year-old man presents to your clinic with a 3-week history of increasing fatigue, jaundice, and abdominal discomfort. He admits to drinking approximately a pint of vodka daily for the past 15 years. On physical exam, he is noted to have scleroicterus, spider agiomata, and enlarged tender liver. Lab results shows an AST that is 320, ALT 140, total bilirubin 6.2, albumin 2.8, platelet 110,000 with an INR of 1.9. Abdominal ultrasound shows a liver with increased echogenicity and no focal lesions or signs of ascites. Which of the following is the most likely diagnosis? Viral hepatitis, non-alcoholic fatty liver disease, primary biliary cirrhosis, alcohol-related hepatitis, or hemochromatosis? The correct answer is D, alcohol-related hepatitis. The patient's presentation of jaundice, fatigue, and abdominal discomfort combined with his significant history of chronic alcohol use and physical exam findings such as scleroicterus, spider agiomata, and tender hepatomegaly strongly suggest alcohol-related hepatitis. The lab results show a characteristic elevated AST to ALT ratio, typically greater than 2:1, and other indicators of liver dysfunction, such as a high bilirubin, a low albumin, thrombocytopenia, and a high INR. Ultrasound findings of increased liver echogenicity further support the diagnosis of alcohol-related liver disease. Other options like viral hepatitis, non-alcoholic fatty liver disease, primary biliary cirrhosis, and hemochromatosis are less likely given the patient's clinical context and history of alcohol abuse. So what is alcohol-related hepatitis? Alcohol-related hepatitis is most often diagnosed clinically, with liver biopsy reserved for diagnostic uncertainty. The clinical diagnosis includes a patient who has a heavy alcohol intake with at least 3 per day in women and 4 per day in men for a prolonged duration, at least 60 days. A patient may have been abstinent prior to onset of jaundice or hyperbilirubinemia, although period of abstinence should not exceed 60 days. The onset of jaundice should be within prior of 8 weeks. The AST has to be at least 50, and the AST has to at least be 1.5 times as high as the ALT. And hyperbilirubinemia with a serum total bilirubin of more than 3 is indicative of alcoholic-related hepatitis. Severity of alcohol-related hepatitis has historically been determined by the Maddrey Discriminant Function Score. However, the MELD score, or Model for End-Stage Liver Disease, is now the preferred scoring instrument to assess severity, predict mortality, and guide steroid therapy in alcoholic hepatitis. A MELD score that is greater than 20 suggests severe liver disease. Here's a case of a 50-year-old male patient presents to the ED with a 3-week history of worsening jaundice, abdominal pain, and confusion. He has a history of heavy alcohol use, consuming a bottle of whiskey daily for the past 20 years. On physical exam, he is disoriented, has scleral icterus, spider agiomata, ascites, and a tender and large liver. Lab results show an AST of 300, ALT 100, total bilirubin 22, albumin 2.1, platelet 90,000, and an INR of 2.4. The serum creatinine is 1.6. We calculated a MELD score, and it's 26. Which of the following is the most appropriate next step in the management of this patient? Initiate antiviral therapy, administer IV fluids and supportive care only, start prednisolone, perform an immediate liver biopsy, or refer for liver transplant evaluation. The correct answer is C, start prednisolone. The patient presents with severe alcohol-related hepatitis, evidenced by significant jaundice, abdominal pain, confusion, and a history of chronic heavy alcohol use. The lab findings show a markedly elevated AST to ALT ratio, high bilirubin, low albumin, thrombocytopenia, high INR, and an increase in serum creatinine. These findings indicate severe liver dysfunction. A MELD score of 26 further confirms the severity of the condition. In cases of severe alcoholic hepatitis, particularly with a high MELD score of at least 20, steroids such as prednisolone are recommended to reduce liver inflammation and improve short-term survival. Therefore, starting prednisolone is the most appropriate next step in the management of this patient. Antiviral therapy, supportive care alone, liver biopsy, and immediate referral for liver transplant evaluation are not the initial priorities. The use of prednisolone is specifically indicated for severe alcoholic hepatitis to manage the acute condition. Again, in severe cases of alcohol-related hepatitis with a MELD score of more than 20, treatment with prednisolone is recommended. Contraindications to prednisolone include active infection, an upper gastrointestinal bleed, severe kidney injury, concomitant liver disease like hepatitis C virus or hepatitis B virus, and multi-organ failure. Why prednisolone? Well, prednisolone has demonstrated short-term but not long-term mortality benefit, with the mortality benefit was only at 28 days from treatment initiation and not at longer follow-up periods. Notably, treatment with prednisolone is associated with increased risk of infection, and use of corticosteroids is controversial with significant variability between medical centers on its use. What about alcohol-associated fibrosis and cirrhosis? Well, this is the final stage in the spectrum of alcohol liver disease and represents irreversible liver injury. While classically these were histopathological diagnoses, non-invasive testing has been increasingly used to support the diagnosis and avoid the need for liver biopsy. Blood-based biomarker risk scores such as FIB4 and APRI index, which is AST to platelet ratio index, have been validated for use in alcohol liver disease and can be suggestive of advanced liver disease. Fibrosis 4, or in short FIB4, is a clinical marker used to evaluate the degree of liver fibrosis. It is a non-invasive test that helps us assess the extent of liver damage without the need for a liver biopsy, which is more invasive. The FIB4 index is calculated using a simple formula that includes the patient's age, levels of two liver enzymes, AST and ALT, and platelet count, as shown on the left side. A score of less than 1.45 suggests that cirrhosis is less likely. A score or more than 3.25 suggests that cirrhosis is more likely. There are several overarching concepts when it comes to caring for a patient with alcohol liver disease. What do you think is the single most important factor for improving survival in alcohol-related liver disease? It's alcohol cessation. Complete abstinence from alcohol is the single most important factor for improving survival in alcohol-related liver disease. With complete cessation, hepatic steatosis and inflammation can regress, and progression of alcohol liver disease can be slowed, although liver fibrosis is typically irreversible. In contrast, with continued alcohol consumption, liver disease will almost certainly progress. What pharmacotherapies and psychosocial treatments can be used as part of alcohol cessation regimen? FDA-approved medications for relapse prevention in patients with alcohol liver disease are naltrexone and acamprosate and are considered first-line treatments. Multiple non-FDA approved medications may have some benefit in relapse prevention, and this includes gabapentin, baclofen, and topiramate. Naltrexone is an opioid receptor antagonist and can be dosed daily or with monthly subcutaneous injections. It undergoes hepatic metabolism and can cause hepatotoxicity. It has not been studied in patients with alcohol-related hepatitis or alcohol-related cirrhosis. Acamprosate is a NMDA receptor antagonist. The dose is 3 times daily. There's no reported hepatotoxicity, but should not be used in patients with severe renal dysfunction. Disulfiram is FDA approved for alcohol use disorder, but not in patients with alcohol liver disease. Psychosocial and behavioral therapies include referral to substance use disorder specialists, motivational interviewing, social support groups like Alcoholics Anonymous, outpatient or residential sobriety programs. Patients with alcohol liver disease, and in particular those who continue to consume alcohol, tend to have poor nutritional status, and a healthy diet with appropriate vitamin supplementation is imperative. Guidelines recommend a high-protein diet for patients with alcoholic steatohepatitis or cirrhosis in combination with a low-sodium diet if stigmata of portal hypertension are present. Additionally, patients who continue to drink alcohol or those who recently attained sobriety should take a daily folic acid, vitamin B12 complex, and thiamine supplement. There is also data suggests zinc supplementation may be beneficial. For those patients with alcohol-associated cirrhosis who do not recover liver function with alcohol cessation, referral to a transplant hepatologist is appropriate to consider candidacy for liver transplant. Requisite criteria for liver transplant vary across treatment centers. Now let's do some rapid-fire concepts. Alcohol liver disease includes alcohol-related fatty liver, alcohol-related hepatitis, and alcohol-related cirrhosis. A male patient who drinks at least 4 beer in a single day or a female patient who drinks at least 3 beer in a single day is at increased risk for alcohol-related problems. Audit C is a validated questionnaire used to screen for alcohol use disorder. Know the clinical criteria for alcohol-related hepatitis before you take your exam, and a MELD score of more than 20 suggests severe liver disease, and the primary treatment is prednisolone. FIB-4 score is used to evaluate the degree of liver fibrosis without the need for a liver biopsy, which is invasive. The single most important factor for improving survival in alcohol-related liver disease is alcohol cessation, and the first-line treatment for alcohol use disorder includes naltrexone and acamprosate. Thank you and good luck.